and a pleasure too to be sharing the session with Wendy Savage, whom I've been aware of for a long time, both as a pioneer activist defending her own rights and the rights of colleagues, but also as an advocate for the National Health Service. What I want to do in this first section is to give a kind of context to the reforms. So it's a large bill, as you will be aware. It's larger than the original 1946 bill in terms of its sections and clauses, and I'm not, you may be relieved to discover, we're going to wade through that, but to talk more about its general thrust and to try and put that into something of a social context. And there'll just be a little bit of sociology seeping in towards the end, because I want to say a little bit about wealth and power in our society too. It's sometimes considered rude to mention those things, but I think it's important if we understand why what is happening. The basic message, I think, is simple. What we're seeing is a recommodification of healthcare in the UK, and it's bad news. So I want to give a little bit of background, and then to move on to the bill itself. So I'll talk a bit about the nature of the reforms and the setting in which they're taking place, then offer something of a critique of the reforms themselves, suggesting that A, they're not what they purport to be, and B, there's very little evidence that they are likely, possibly can, deliver what the government is leading us to expect from. And then to talk rather more, this is the sociology bit, about what I think is really going on in here, what the government's real agendas are. You will remember, one or two of you, and others of you will know, that when the NHS came into existence, 56 bill, started up in 1948, it was a cross-party initiative. It emerged from the Beveridge report. Beveridge was a liberal. It was accepted by a government led by Churchill, the wartime government. Churchill had been a liberal in a previous life, but was then a conservative, and was put into effect by Clem Attlee, who from 45 to 51 was the Labour Prime Minister. So it was a cross-party effort. And that consensus on the nature of the NHS lasted effectively, with a few hiccups, until Margaret Thatcher's coming in 1979. So there was, if you like, a post-war consensus around the welfare state and the role of the NHS in it. Very quickly, the first attempt to conduct any serious reform was in 1974, and it was more in the nature of a reorganisation. The original NHS had had a tripartite structure, divided between GP services, hospital services, and local authority services. And in 1974, an attempt was made to create a greater degree of integration between those three separate arms. So it was a time when the ideal, not always the practice, was a consensus management involving people across the healthcare delivery service. Thatcher was elected in 1979, and her 1980s saw a different kind of reform take place. She thought, and it came out, we're going to suggest, I don't think it'd be a great surprise, out of her ideological position, that the NHS was unsatisfactory as it was, and the way to improve it was to introduce, as far as was possible, a better management system and markets. So she asked Roy Griffiths, who was then head of Sainsbury's, and who better, obvious overlap between healthcare delivery and selling sausages, to go through the NHS and suggest a better management structure for the NHS. And predictably, what emerged was a more corporate structure, a more business model. So pared down management with someone at each level accepting that the buck stops here. This is where the decision making ended. Now, regardless of the merits or criticisms one might want to level against that new management structure, it was the ethos of the time. What happened towards the end of Margaret Thatcher's period was the introduction of what we can't really look upon seriously as a marketplace in healthcare, a kind of pseudo-market, the internal market, but a division between those who purchased healthcare and those who provided healthcare. Not a real market, because they were often the same people doing this purchasing and providing. And how had this come about, this strange innovation? Because she was looking towards the US for the model of how better to run a healthcare system, and Eindhoven was her advisor. Now, how you would look across the Atlantic to learn how better to run a healthcare system is bizarre. I mean, the proportion of the GDP in Britain being committed to healthcare was just over 5% at that time. The Americans were already well over 10. And interesting, this is a point I shall return to. The proportion of our health budget committed to administration was around 5%. The proportion of the American budget committed to administration was 25%. So the notion that we should look to America in order to introduce markets because markets lead to the more efficient delivery of healthcare is bizarre. There must be something else going on. What we saw in the Labour era was a period of restructuring of healthcare, and I'm not going to delay that because we want to get on to the present, just to mention 2007, the introduction of primary care trusts as commissioning agents. So what we're seeing is a movement on from what Labour had introduced in 2007. But a managerial thrust, looking to the marketplace to provide solutions. What we're seeing is a Labour period of Blair being interested in markets, Brown a little less so, but stalling on a number of innovations. And then we've moved on since to a new coalition approach. A few things that I haven't mentioned very briefly. First of all, after the party political consensus broke down, I think we've seen more continuity through Conservative Labour coalition regimes than people realise. The general trend has been in the same direction. Sold, of course, as progressive, but I would argue in general terms, regressive. I mentioned bureaucracy and suggested that the NHS, before we started reforming it, was really quite an efficient institution. And the American healthcare system rather less so. Galbraith, the American economist, said it's odd that when we look at the public sector, particularly an organisation like the NHS, it screams out bureaucracy to us. It's as if bureaucracy in the private sector is somehow invisible. We're conditioned to see it in the public sector, and we somehow miss it in the private sector. And yet, if you're looking for bureaucracy in a healthcare system, you go to the US, not to the British National Health Service before people started reforming. I wanted to say a word too about what I think was an important innovation, private finance initiatives, brought in by John Major in 1992. And this, of course, was involving the private sector in the building of our hospitals, our schools, and so on. The political virtue was that that expenditure disappeared, as it were, from government accounts, and it looked like we were getting something on the cheap. People like Alison Pollock, who opposed PFIs from the outset, I think rightly so, argued to the contrary. We will be paying an awful lot more for these buildings and these resources in the future than governments were willing to accept. And her team, interestingly, used the Freedom of Information Act to ask what evidence the Treasury had that PFIs were a good deal. Because what we're hearing was that they led to not only new wonderful buildings, but were an efficient way of constructing those buildings. And the Treasury reluctantly, after a period of some months, came out with one sheet of A4 with a few figures scrawled up. They didn't have the evidence that this was a good buy. So I think this is an important change to which we're going to add the coalition initiatives. And finally, just to mention population health, and to make the point that the health of a population bears some but not a very convincing relationship to how we deliver healthcare. If we're looking at the health of populations, then we're looking at deeply structured social inequalities that, as it were, deliver health inequalities. Now, our healthcare system, just like schools, can do a little about that, but not too much. So the notion, and we've heard this from Andrew Lansley as well, that the new arrangements will somehow alleviate health inequalities is, well, A, it's false, and B, it's perverse, because what it will do, if anything, is accentuate them rather than diminish them. Another couple of very quick contextual points. It was in the Labour government, mid-2009, that the chief executive said we have to make savings. So before we've introduced a package of radical reforms of the NHS, we are committed to making very significant savings, around 4% a year for the next few years, and we must factor that in. The private sector has also been organised. In December of last year, a new alliance with the 5 major private providers, known as H5, formed an organisation to work together to further their interests at the time of the NHS reforms. And H5 between them account for 4 out of 5 UK private hospitals and 85% of all our private beds. The BMJ. What do you call a government that embarks on the biggest upheaval of the NHS in its 63-year history at breakneck speed, while simultaneously trying to make unprecedented financial savings? The politically correct answer has got to be mad. Now, the maybe is mine. I don't think they're mad at all. I think they're doing something else. There are 5 themes that run through this health and social care bill. It is designed, we're told, to strengthen the commissioning of health services and social services, increase democratic accountability, liberate the provision of health service, strengthen public health services, going in the direction of local authorities, and reforming healthcare arm's length bodies, quangos and so on. It's good language, isn't it? Democratic accountability, liberating, and so on. Gilbert Ryle philosophy used to call those hurrah words. You can't disagree with them. How could you possibly argue with any of this? Doesn't mean it's going to deliver it, of course. At the centre of the bill is the notion that by April 2013, the existing 152 primary care trusts will be abolished, and GPs will be obliged, all of them, to join commissioning consortia. These consortia will between them control 80% of the NHS budget. And the services will be purchased from, quote, any willing provider. I'm going to come back to these things when I suggest a critique. All NHS hospitals will be foundation trusts by 2014. About half currently are. So they'll be more like autonomous business units than some hospitals at the moment are. And this commissioning process will be overseen by a financial regulator already in existence, known as Monitor. There'll be upfront costs. The figures put on it vary, it seems, from one document to another, but in excess of £1 billion, including around £1 billion for redundancies. The expectation, I think, is about 50–70% of staff will switch over from PCTs to the commissioning regimes, but these are guesses or guesstimates of what is likely to occur. Similarly, there are different guesstimates of administrative savings. We see figures of a third, we see a figure over a long period of time, 45% saving on administrative costs. And we're told that local decision making by those best placed GPs will offer more patient choice. Again, it seems difficult to argue that unless we ask what it means. Why, one question is, should commissioning consortia be better than PCT, who currently do the commission? What will the role of private companies in relation to commissioning consortia turn out to be? And what is the role of Monitor? And I made a reference there to EU law. we already have about 10 or so consortia up